Psychological impact of pediatric rheumatology, a review. Pediatric rheumatologic diseases such as juvenile idiopathic arthritis, JIA, systemic lupus erythematosus, SLE, and juvenile dermatomyositis, JDM, have profound impacts beyond the physical symptoms. These diseases, characterized by chronic inflammation, pain, and functional limitations, significantly influence the psychological and emotional well-being of both the affected children and their families. Psychological impact on children. 1. Emotional distress. Chronic pain. Persistent pain contributes to feelings of frustration, sadness, and anxiety. Disease unpredictability. Flare-ups and remission periods create uncertainty, heightening anxiety and fear. 2. Social isolation. Children may feel alienated from peers due to physical limitations or frequent medical appointments. Missed school days can lead to academic challenges and difficulty maintaining friendships. 3. Body image and self-esteem. Physical changes such as joint deformities or corticosteroid-induced weight gain can result in poor self-image. 4. Cognitive impact. Fatigue and chronic inflammation can impair concentration and memory, impacting academic performance. Impact on families. 1. Parental stress. Parents often experience guilt, anxiety, and helplessness regarding their child's condition. The need for constant caregiving can lead to burnout and affect family dynamics. 2. Siblings. Healthy siblings may feel neglected or burdened by increased responsibilities. 3. Financial strain. The cost of medications, frequent doctor visits, and therapies can be significant, compounding stress. Long-term psychological outcomes. Without proper support, children with pediatric rheumatologic diseases may face depression, higher prevalence than in the general pediatric population. Anxiety disorders, especially related to health and social interactions. Post-traumatic stress, due to invasive medical procedures and prolonged hospital stays. Strategies for mitigation. 1. Psychological support. Regular counseling or therapy for both the child and family. Cognitive behavioral therapy, CBT, for managing pain and emotional challenges. 2. Support groups. Peer support networks for children and caregivers can reduce isolation. 3. Holistic treatment approach. Collaboration between rheumatologists, psychologists, and educators to address medical, psychological, and academic needs. 4. Educational interventions. Informing schools and peers about the child's condition to foster understanding and accommodations. Research is ongoing to better understand the biopsychosocial impact of these diseases. Interventions integrating psychological care into routine rheumatology practice hold promise for improving quality of life for children and families. This review underscores the necessity of addressing the psychological dimensions of pediatric rheumatologic diseases alongside physical symptoms, advocating for a comprehensive approach to care. Role of family, society, school, and healthcare providers in pediatric rheumatology. The management of pediatric rheumatologic diseases involves a multidisciplinary approach, where the family, society, schools, and healthcare providers play pivotal roles in ensuring the holistic well-being of the child. 1. Family's role. Emotional support, providing stability. Families act as the primary source of emotional comfort during flare-ups and treatment. Encouraging resilience, building the child's confidence to manage their condition. Practical support, medication management, ensuring adherence to prescribed treatments and follow-up visits. Daily care, assisting with activities of daily living if physical limitations arise. Advocacy, communicating needs, advocating for the child's requirements in school and medical settings. Empowering independence, encouraging the child to take responsibility for self-care as appropriate. Challenges for families. Parental burnout, balancing caregiving with personal and professional responsibilities. Siblings' needs, ensuring equitable attention to siblings who may feel neglected. 2. Society's awareness, reducing stigma, promoting understanding of pediatric rheumatologic conditions to avoid misconceptions. Creating support systems, establishing community-based resources like support groups for affected families. Inclusion and accessibility. Sports and activities, adapting recreational activities to include children with physical limitations. accessible environments, ensuring public spaces are accommodating for mobility aids. 3. Schools' role, educational support, individualized education plans, IEPs, tailoring learning environments to the child's needs, e.g., extended test times, modified physical education. Teacher training, educating staff about the child's condition and how to support them effectively. Social inclusion, encouraging peer interaction, promoting an inclusive atmosphere to prevent isolation. Anti-bullying measures, ensuring that the child is protected from stigma or discrimination. Flexibility in attendance, attendance policies, allowing for absences due to medical appointments or flares without penalty. 4. Healthcare providers' role, medical management, accurate diagnosis, early identification and treatment to minimize disease progression. Comprehensive care, multidisciplinary collaboration among rheumatologists, physical therapists, and psychologists. Psychological support, counseling services, addressing anxiety, depression, and coping mechanisms. Pain management, integrating non-pharmacological strategies like CBT and physical therapy. Education and empowerment, patient education, teaching families and children about the disease, treatment options, and self-management strategies. Transition of care, preparing adolescents for the shift from pediatric to adult rheumatology services. Advocacy and research, policy development, advocating for better healthcare access and coverage for chronic pediatric conditions. Research contributions, supporting studies that address the psychological and social impacts of these diseases. Conclusion. The successful management of pediatric rheumatologic diseases requires a coordinated effort among families, society, schools, and healthcare providers. Each stakeholder has a unique role in fostering the child's physical, emotional, and social development, ensuring a better quality of life and long-term outcomes. Use of psychiatric medications in pediatric rheumatology. Children with pediatric rheumatologic diseases, e.g. juvenile idiopathic arthritis, systemic lupus erythematosus, often face psychological challenges, including depression, anxiety, and adjustment disorders, arising from chronic pain, functional limitations, and social isolation. Psychiatric medications can play a supportive role in managing these conditions, but their use requires careful consideration of benefits, risks, and precautions. Potential benefits. 1. Management of depression. Antidepressants like selective serotonin reuptake inhibitors, e.g. fluoxetine, sertraline, can alleviate symptoms of depression, improve mood, and enhance coping mechanisms. 2. Reduction of anxiety. SSRIs and serotonin norepinephrine reuptake inhibitors, e.g. duloxetine, can help reduce anxiety, which is common in children with chronic illnesses. 3. Improvement in sleep disorders. Low-dose sedative medications, e.g. trazodone, can help address sleep disturbances caused by chronic pain or corticosteroid-induced insomnia. 4. Pain management. Certain antidepressants, such as amitriptyline or duloxetine, have shown efficacy in managing chronic pain syndromes, including fibromyalgia-like symptoms associated with rheumatologic conditions. 5. Adjunctive therapy for behavioral issues. Mood stabilizers or antipsychotics may be considered in rare cases for managing behavioral or emotional dysregulation, often in collaboration with a psychiatrist. Possible. Side effects. SSRIs and SNRIs may cause gastrointestinal upset, agitation, headache, or rarely suicidal ideation in children. Tricyclic antidepressants, TCAs, can lead to drowsiness, weight gain, and cardiac side effects, particularly at higher doses. Antipsychotics, associated with weight gain, metabolic syndrome, and extrapyramidal symptoms. 2. Drug interactions. Many psychiatric medications interact with immunosuppressive drugs or corticosteroids commonly used in rheumatology, potentially altering efficacy or increasing toxicity. 3. Disease flare risk. Some medications, like bupropion, may trigger seizures in predisposed patients or exacerbate systemic symptoms, requiring caution. 4. Dependency and misuse. Benzodiazepines, rarely used in pediatrics, carry a risk of dependency and are generally avoided in long-term management. 5. Long-term developmental effects. The impact of psychiatric medications on the developing brain is not fully understood, necessitating careful long-term monitoring. Precautions. 1. Multidisciplinary collaboration. Involve pediatric rheumatologists, psychiatrists, and primary care physicians in decision-making to ensure comprehensive care. 2. Individualized treatment plans. Tailor medication choice and dosing to the child's specific psychological needs, physical health, and medication history. 3. Monitoring for side effects. Regular follow-ups to monitor for adverse effects, particularly behavioral changes, weight, and metabolic parameters. 4. Psychoeducation. Educate the child and family about the purpose, benefits, and potential risks of psychiatric medications. 5. Non-pharmacological interventions. Combine medication with non-pharmacological approaches such as cognitive behavioral therapy, CBT, mindfulness, and family counseling to optimize outcomes. 6. Short-term use when possible. Use medications for the shortest duration necessary, particularly in cases of situational anxiety or depression. Conclusion. Psychiatric medications can be valuable in addressing the emotional and psychological challenges faced by children with pediatric rheumatologic diseases. However, their use should always be approached with caution, emphasizing a balanced, multidisciplinary approach to care. By carefully weighing the benefits and risks, healthcare providers can improve the child's overall quality of life while minimizing potential adverse effects. Role of cognitive behavioral therapy, CBT, in pediatric rheumatology. Cognitive behavioral therapy is a structured, evidence-based psychological intervention that focuses on modifying negative thoughts, behaviors, and emotional responses. In pediatric rheumatology, CBT plays a critical role in managing the psychological and behavioral challenges associated with chronic diseases like juvenile idiopathic arthritis, systemic lupus erythematosus, SLE, and juvenile fibromyalgia. Key benefits of CBT in pediatric rheumatology. 1. Pain management. Cognitive reframing helps children understand and manage pain by reducing catastrophizing thoughts about their symptoms. Relaxation techniques, breathing exercises, and mindfulness help decrease the perception of pain. Behavioral activation encourages engagement in enjoyable activities, which can distract from pain and improve overall mood. 2. Coping with chronic illness. Problem-solving skills teaches children how to approach disease-related challenges systematically. Building resilience enhances the ability to adapt to flare-ups and functional limitations. Self-efficacy improves confidence in managing their condition, including adhering to treatment plans. 3. Emotional regulation. Anxiety and depression reduction addresses maladaptive thought patterns contributing to these conditions. Stress management teaches strategies to handle stress associated with chronic illness and medical procedures. 4. Improved sleep. CBT for insomnia, CBTI, is effective in managing sleep disturbances common in pediatric rheumatologic diseases by addressing behaviors and thoughts that disrupt sleep. 5. Enhancing social functioning. Peer interaction helps children overcome social withdrawal and improve relationships with peers. Conflict resolution provides tools to handle misunderstandings or stigma related to their condition. CBT techniques used in pediatric rheumatology. 1. Cognitive restructuring, identifying and challenging negative thoughts like "I'll never feel better" or "I can't do anything right," replacing them with balanced, positive beliefs. 2. Behavioral strategies, gradual exposure to activities that the child avoids due to fear of pain or failure. Developing a reward system to reinforce adherence to physical therapy or medical routines. 3. Psychoeducation, educating children and families about the relationship between thoughts, feelings, and behaviors. Providing information on how chronic pain is influenced by stress and emotions. 4. Relaxation training, techniques like progressive muscle relaxation, guided imagery, and mindfulness meditation. 5. Problem-solving training, teaching step-by-step methods to approach challenges, such as difficulty attending school or dealing with fatigue. Role of CBT in family dynamics. Parental involvement. CBT often involves parents to improve family communication and reduce parental stress. Family-centered therapy helps families develop shared goals and strategies for managing the child's condition. Efficacy and evidence. Studies have shown that CBT significantly improves pain, fatigue, and quality of life in children with chronic illnesses, including rheumatologic conditions. Long-term benefits include reduced healthcare utilization and improved adherence to treatment plans. Conclusion: CBT is an invaluable tool in the multidisciplinary management of pediatric rheumatologic diseases. By addressing the psychological aspects of chronic illness, CBT empowers children to better manage their symptoms, enhances their emotional well being, and improves their overall quality of life.